Bismillah ar-Rahman ar-Rahim. I'd like to thank the conference committee for inviting me to this session. I'd like to talk about CSF hydrodynamics. And when we talk about CSF, we are talking about an ultrafiltrate of plasma which encircles the brain and the spinal cord. Its volume is about 150 milliliter. From them, about 125 milliliter inside the subarachnoid space and only 25 millimeter inside the ventricles. And its secretion is about 400 to 600 millimeter per day, which means it's renewed 3 times per day. It is secreted by a highly specialized epithelial cells within the choroid plexus, about 90%, and it's the main route of production. These cells have microvilli which are interconnected together, forming what's called a blood CSF barrier. And this barrier help regulate CSF contents. We know now there is another minor route of production inside the brain parenchyma itself, and it's about 110%, and we will talk about it later. Its absorption is mainly through the transdural absorption through the arachnoid villi, depending on the pressure gradient between the CSF and the veins, and also there is a parenchymal absorption through the ventricular wall into the cerebral parenchyma, which is mediated by what's called aquaporin-4 channels. Function of CSF is simple: protection, nourishment, and waste removal. So how the CSF circulates? It was previously known that the CSF is a unidirectional, and it continuously produced from the choroid plexus, and which create a pressure gradient. So the CSF is moving from the lateral ventricle to the third through the foramen of Monroe, and then through the aqueduct into the fourth ventricle, and from the fourth ventricle to the subarachnoid space through the foramen of Loschke and Magendie. And this process is mediated by the different pressure gradient between different compartments. And this is an illustration of the bulk flow theory, which reveals that the source from the choroid plexus and the movement of the CSF down to the drainage site, to the arachnoid villi and the lymphatics. And we know now there is another theory of CSF flow, which is called the Monroe-Kelly doctrine, and it states that the different components of the intracranial should be kept constant, which means that the brain contains CSF volume, contain blood volume, and contain brain tissue. And all these constituents should be kept stable. So if one of them increase its volume, it should be compensated by decrease in the other component. For example, a brain tumor will increase the brain volume, should be compensated by decrease in the CSF or blood flow. And if this compensatory mechanism fails, the patient will develop increased intracranial pressure. And the Monroe-Kelly doctrine also explains how the CSF moves, which is not mediated by the pressure gradient as was thought before. It's actually mediated by the blood flow and pulsatility of the arterial wall. So during systole, there is increase in the blood going to the brain. It should be compensated by drainage of CSF from the brain, and this keeps the brain tissue stable and intact. And this is reversed during diastole, so the blood flow to the brain decrease, so it will be compensated by increase in the CSF inside the brain to compensate for the volume loss. And this was confirmed, this bidirectional flow of CSF was confirmed by phase contrast MRI, in which, as you can see here, the flow of the CSF through the prepontine cistern and through the aqueduct of Sylvius. You can see an alternating band of white and black, which means that the flow is reversed during systole and diastole. And we can qualitatively assess the CSF also using what's called a mid-sagittal view, heavy T2 weighted image, in which we can assess the aqueduct of Sylvius, the third ventricle, and the lateral ventricle, and the recesses of the third ventricle, also the fourth ventricle and the subarachnoid cisterns. Quantitatively, we can assess the CSF using what is called a CSF flow metric study through measuring the CSF across the aqueduct of Sylvius, and it gives me numerical values regarding the CSF flow rate, flow velocity, and stroke volume. And now we have what is called the perivascular spaces. It's called Virchow-Ropin spaces, and these are fluid-filled spaces surrounding the arteriole and venules when penetrating inside the brain parenchyma. It was seen incidentally, and it's usually asymptomatic. When it's more than 2 millimeter, we call it enlarged perivascular space, and it can be bizarre shape and enlarged, and we call it a giant or tumefactive perivascular space. And these are three types of perivascular spaces. Type 1, according to the location, type 1 is the basal ganglia accompanying the lenticulostriate arteries. Type 2 in the subcortical white matter accompanying the medullary arteries. And type 3 in the pontomesencephalic region accompanying the collicular arteries. And this is a schematic presentation of the perivascular space which is surrounding the arteriole when penetrating into the brain parenchyma. And an example of perivascular space, a very common example is here, basal ganglionic dilated perivascular space. It is CSF signal in all pulse sequences. You can see it as small dots, and it's surrounded in the axial view, and in the coronal images, it's longitudinal or oval shaped. This is type 2 perivascular space. It's a giant, it's a bizarre shape as you can see here. However, this patient is neurologically free because it is actually asymptomatic lesions. And as you can see, it's following the medullary arteries and called tumefactive perivascular spaces. Another type is the type 3, which is seen in the pontomesencephalic region. It's the thalamus and the brainstem, and sometimes it can get bigger and bigger and causing obstruction of the CSF outflow, as in this patient, causing supra-dilatation of the lateral ventricles. Sometimes we see an association between perivascular spaces and other disease. For example, here, this patient had perivascular space enlarged, type 2 in the subcortical region of the parietal lobe. And we can see this patient also had an increased intracranial hypertension, idiopathic intracranial hypertension, as you can see in empty cella, and increased perioptic CSF. And I'd like to talk about a little bit about the lymphatic system, which is a very important topic in neuroradiology nowadays. It was discovered about 10 years ago, and it explains how the brain gets rid of its waste products and through what is called the perivascular spaces. So what is happening is now the arterial wall, which is penetrating inside the brain parenchyma, it's accompanied by the perivascular space, and through the arterial pulsation, the fluid inside this space going into the brain parenchyma and mixed with the interstitial fluid inside the brain parenchyma. This process is mediated by the aquaporin 4 channels in the astrocytic end feet, and this fluid is now mixed with the waste product, especially beta amyloid protein and tau protein, and through the arterial pulsation, it's going from the arterial side to the perivascular spaces around the veins, and then it's drained to the circulation. And we know now that the lymphatic system is activated during sleep. So when you stay awake for a long time, the waste product is accumulated inside your brain, and it interfering with the neuronal signal, so you become confused, you become dizzy, and when you go to sleep for a few hours, the waste product is now cleared, and now you wake up refreshed. And this is an illustration of this process, as you can see here. This is a perivascular spaces fluid is going inside the brain parenchyma, washing all these blue dots, which is a waste product, towards the venous perivascular space and then to the circulation. And we know now the lymphatic system is linked to other diseases, and it's a study of research in many topics, including the hydrocephalus and syringomyelia, idiopathic intracranial hypertension, hypertensive encephalopathy, neurodegenerative disease, especially Alzheimer's disease, in cerebral amyloid angiopathy, traumatic brain injury, white matter diseases, including vasculitis and demyelination, and also it's linked to small vessel disease. And we know now a new classification of hydrocephalus based on Dr. Ann Osborne 2018, and she classified hydrocephalus into 4 main groups. Intraventricular obstructive hydrocephalus due to obstruction of the outflow of the CSF at any level till the level of the foramina flushka and Magendie. And there is extraventricular CSF flow obstruction to the CSF flow through an obstruction at the level of the subarachnoid space. For example, in case of leptomeningeal metastasis or subarachnoid bleeding. And there is also normal pressure hydrocephalus when there is no obstruction to the CSF, but actually there was a hyperdynamic CSF circulation that causes ventricular dilatation. And lastly, there is a hydrocephalus due to overproduction of CSF, and I'll give you some example of each. So first group is intraventricular obstructive hydrocephalus. We have here an intraventricular tumor. It's a very big tumor. It's occupying the lateral ventricle and encroaching on the foramen of Monro, causing obstruction. It's elicit a high signal on T2, a dirty appearance on flare, which is characteristic, and diffusion restriction, it's high. So we are talking about an intraventricular epidermoid cyst. Another example is a tumor which is located at the level of the foramen of Monro. It's causing asymmetrical hydrocephalus, so the left ventricle is dilated more than the right one, and we are talking about subependymal giant cell astrocytoma. Another one is the colloid cyst, typical appearance, roof of the third ventricle, obstructing both foramina of Monro on both sides. And going down, we have an obstruction at the level of the aqueduct of Sylvius. We have many pathology, including congenital, as in this case. We can see there is a diaphragm or web obstructing the aqueduct of Sylvius, causing supratentorial hydrocephalus. Another obstruction of the aqueduct of Sylvius through a tumor. Here there is a tectal glioma compressing the aqueduct of Sylvius, resulting in supratentorial hydrocephalic changes. And going down, we have an obstruction at the level of the fourth ventricular cavity, the large mass, which is seen at the CB angle, right CB angle, and compressing the fourth ventricular lumen associated with hydrocephalus. And this lesion is high signal on T2, again, dirty signal on flare, and high signal or diffusion restriction on DWI. It's again a CB angle epidermoid cyst. Another infiltrative lesion of the brainstem, it's a brainstem glioma or pontine glioma, which is large lesion involving the brain, the bones, and extending posteriorly, causing compression of the fourth ventricular cavity, almost totally occluded, and resulting in supratentorial hydrocephalus. The next category is the extraventricular obstruction of hydrocephalus, and this is obstruction at the level of the subarachnoid spaces. And for example, there is infection, there is a subarachnoid bleed, and there is a leptomeningeal metastasis. All these are causes, and this patient here have Cryptococcus meningitis. As you can see, there is a small locules which are not of this organism. It's occupying the subarachnoid space and also a dilated perivascular spaces. And as you can see, there is enhancement in the meninges, in the leptomeningeal and basal meninges. Third category is normal pressure hydrocephalus, which is a triad of dementia, ataxia, and urinary incontinence. Not typically in all cases. There is no obstruction here, but there is a hyperdynamic circulation of CSF, and this hyperdynamic circulation causing ventricular dilatation. And this is a conventional imaging of normal pressure hydrocephalus. Typical finding: subcallosal angle is narrowed. Here is less than 90 degrees. There is thinning of the posterior aspect of the corpus callosum, and there is widening of the subarachnoid space, especially the Sylvian fissure, out of proportion of the involutional change of the brain. And lastly, there is a hydrocephalus with CSF overproduction, and a typical exam of this is the choroid plexus papilloma, which is secreting CSF not only inside the ventricular cavity but also inside the brain parenchyma through transependymal CSF flow, and causing overproduction of CSF and hydrocephalus. So take-home message is CSF control is a complex and delicate process. CSF hydrodynamics is not yet fully understood. The link between CSF and other neurological diseases is still under investigation, and there are many studies regarding this. A new understanding of hydrocephalus is being applied, and please sleep well. It keeps clearing cerebral waste product through the lymphatic system. Thank you for listening, and I hope I finish on time.